We're so honored to be presenting today and meeting some of the folks who've joined us here. Zooming out for a second, every community has a safety net, but the problem is that the need is greater than it's ever been before, and the net isn't proportionally bigger or wider than it was, 10 years ago. And so, what does that mean? Well, it means that it's especially hard to provide care fast enough for people who may not live near central access hubs, or maybe they do, but maybe they have other healthcare needs to address. And that's where, the Brave model, I think, is powerful in multiple different contexts. And for people who are pregnant or recently gave birth, that's really one of them. And we'll talk about that a little bit more in a moment. But when we zoom out, what we were doing at Brave is we asked ourselves, what we're doing here is we asked ourselves the question, what would happen if we could take the community mental health center model, which does really important services and amazing, amazing work in communities, and made it available everywhere to an unlimited number of people, not to replace the amazing work that happens in communities. I love the idea of mobile care that you're talking about, Sunny. I think there's always going to be a need for brick and mortar services. There's always going to be a need for places where individuals can go in their communities. But what would happen if we added sort of an overlay layer and said, okay, that's amazing, but when we need fast access in certain areas where maybe there aren't as many resources, or maybe it's somebody who lives far away from those resources, or just like we were talking about already today, has transportation barriers, childcare barriers, right? What would happen if we could add in a virtual layer? And so that's what we've created. So at Brave, we offer a national virtual community mental health center and engagement platform model. We deliver behavioral health services, really treating a number of conditions across the full spectrum of things that can be treated outpatient, from, mild depression to schizophrenia. It's really a mix, and about, I would say, 30 to 40% of our patients do fall into the category of people with serious mental illness. Everything's done virtually. So it's a fully virtual platform, but our care is primarily delivered through synchronous video, just like what we're doing right now. That being said, the virtual platform doesn't stop with care. We're also doing a ton of work with engagement in between and around sessions and before people ever become patients, in order to get them into care faster and keep them in care. And when I say we're complexity ready, what I mean by that is this isn't just about, creating a self-serve virtual platform that's available for people who might want it and can navigate care themselves. No, we're really actually talking about taking the community mental health center model, adding technology to make engagement more possible and more broadly available to us, and bring a layer of data as well, and then doing what we would normally do in a CMHC setting virtually. So there's three components of that, like I've spoken to a little bit. The first is our virtual clinic. Therapy, psychiatry, case management, care navigation, peer support, although peer support is something we really want to expand. And I think, Shonik, we should probably talk again about possible partnership opportunities. Integration, so that's a great transition. We don't do everything on our own. We don't believe we can or should do everything on our own. We believe you can either operate within the healthcare system or without it, and we want to be operating within it. That means we're plugging in with health plans, with facilities, with PCPs, and also with OBGYNs when they're the primary treating provider in the context of pregnancy. And then there's that engagement piece. The engagement piece is about the idea that if we left individuals simply to self-navigate the system, we would lose the ability to get people into care, just because life gets in the way, or it's frustrating, or they don't have a ton of trust in the system, things that we can all understand. We want to take away some of those barriers, and it's not perfect, but it does work when we do engagement, both at the onset of care and throughout the process. So what that means is when we add the navigation platform and the provision of services together, we get an approach that leads to an ability to treat people with not just moderate to severe behavioral health conditions like I was talking about, not just folks who may have care navigation needs or SDOH barriers. We at least several times a week, we help people set up an email account. We have hundreds of technology saves per month where we have a patient who wasn't able to use telehealth, and we help them learn how and then get them into care. But also the piece that I want to highlight here is medical complexity, right? So whether that's a temporal situation, right? Maybe that's something that's going on in your life for a given period of time, like pregnancy, or whether it's a chronic medical condition. In both cases, this integrated care model really does work. And so you can imagine there are a lot of populations that what we do could be applicable for, and maternal and postpartum mental health are one of them, or are two of them. So what are we talking about when we say integration and coordination? Well, I know we have some health plan folks on the line, and I want to highlight something because I hope this resonates. But it's not just health plans that we get referrals from; it's also hospitals and also all kinds of other stakeholders, including OBGYNs, PCPs, and doulas. And we're just kind of getting started, I think, in scratching the surface of how we can plug into communities. But in every case, there's something different about the Brave model that we see results from. We don't advertise. Our patients come to us through referral. That means that the patient has indicated some level of readiness to participate in care. Even if it's not a full readiness, there's some interest there. We don't have a lot of time though, right? And if anyone on this call who's ever spoken to a patient about getting started in care knows that you have a window of motivation and that doesn't last forever. So when we get our referral, we reach out directly to that prospective patient within a day. Hi, your case manager, Sunny, told me that you might be interested in getting services. Let's get you started. We're going to keep in contact with you and let's walk through the process. But then we're also sending push updates back to the health plan, back to the other stakeholders as appropriate. And sometimes it's even clinical records. If we're working with a PCP and the patient consents, or if we're working with an OB and the patient consents, we want that clinical engagement to happen. And then at the rolled up level, we're getting population health information that goes back typically to the health plan and helps us make care better together. That can also happen with other providers if they're interested. When we think about what does this loop do? Well, it sounds good in practice, or it sounds good in theory, but in practice, it drives real results. We're able to connect to about 90% of referrals. Typically about 2/3 opt in. And in practice, this ends up meaning that we can get people into care faster. We always offer appointments within fewer than 7 days for new patients. That's always our goal. But it also means that we can drive better health outcomes. And so in an outcome study we did with a managed behavioral health organization, we looked at admissions and readmissions. We were able to reduce readmissions for our participating patients by as much as 90% and reduced costs correspondingly by about 2/3. And this is on the behavioral health side, but there's a medical impact too, physical health impact too, because we know when you're taking care of your mental health, you're taking care of your physical health better too at a population level. And so this is a study we did with a different MCO where we have a ton of pregnant members that we work with there. We work really closely with their pregnant OB case management team. And that's common for us. We were able to reduce medical spend by 16%. And so and we've seen that number range as high as 40%. So we do think that this is not just an intervention that's about mental health. That's where it starts, but it's really about whole person health. And so when we think about what that, some of the key kind of numbers to look at, well, first of all, I want to highlight that 65% of our patients are Medicaid beneficiaries. Primarily, we work with government programs. So it's about 2/3 Medicaid, I'll call it 15% Medicare, and the remainder is commercial, but within commercial, it's almost exclusively individual marketplace. And I think we have some Ohana plan folks on the line. We work a ton with Ambetter, for instance, right? So government programs, that's where we operate. And we're also a TRICARE provider. So I like that was highlighted already. That's something that we see as well. And similarly, we see concentration of TRICARE members in regions where there's a strong military presence. In order to do the kind of engagement work that we do, yes, it happens on the phone, but it also happens through SMS. Our patients love SMS. We send over 15,000 text messages a day. So that gives you a sense of the scale and the fact that this couldn't be done without technology. And that's why when I come back to this idea of a virtual clinic, telehealth is not the innovation. Telehealth is a necessary but not sufficient piece of what we're doing. The innovation is bringing technology not just to care delivery, but to everything that wraps around care delivery and bringing more data, more visibility in to serve populations the best that we can, often focusing on populations that are the most underserved. So a couple case studies and little data share relevant specifically to this population. First, this is one that I would say is just a typical type of patient that we would see. So this is an individual who's a managed care member. They are Medicaid beneficiary living in Florida. Some 23-year-old female. She had aged out of foster care, and when she came to Brave, she was pregnant, isolated, and depressed. She did a lot of work in therapy, and she did what we want someone to do in therapy, right? Not just creating boundaries for herself, working on her trauma, but also working on her parenting skills. Got her first job, enrolled in college, became med compliant, was motivated by breaking the pattern of Child Protective Services involvement and wanting more in life for herself and son. It's amazing to see these stories, right? It's amazing to see what people can do in care. And we believe that care is effective. So the idea with the outreach and engagement is that when we reach people, we can treat them. And if we don't do enough work to reach them, we are never going to be able to do enough to treat them. So let's talk a little bit about how we've been able to reach people. So first of all, 20% of our patients are in super rural areas. And when I see super rural, it's not a formal designation, but I'm referring to the idea that there are 2,500 residents or fewer in the town that this person lives in. So that's 20% of our patients living in towns of 2,500 or fewer. So we are very used to working with rural populations. When we work with doulas, almost 70% of referrals opt into care. That's better than our general population average, which we think is really exciting. When we work with OBGYNs and doulas, we can reach 70+% of individuals, which is great. We've seen it get as high as 90% from health plan referrals, but really we feel like this is really strong. And then we've started to measure our Edinburgh postpartum depression scale ratings, and we've seen a 22% reduction within 90 days of starting care. So you can see the numbers, are there, but there's also a qualitative side that's important. And I loved this quote from a brave patient on one of our patient feedback surveys. She said she has a 17-week-old, a 3-year-old, and a 7-year-old, and being able to get care via the internet, right, lets her not have to think about a babysitter. It can be as simple as that. And then we can reach someone, we can engage them, we can get them the care that we need. We also have been doing a ton of work with an organization called the Doula Network that operates in multiple states. They have hundreds of doulas who treat thousands of Medicaid beneficiaries throughout the year. And I think this is another good example of the kinds of partnerships, like I said, that we can enter into that can help us get the best results. So wrapping it up, as a virtual CMHC, our job is to drive high engagement and powerful outcomes for populations that need it most, especially in rural communities. And what I'll say about that too, because I see some great questions about this, we are a care platform that can be leveraged in different ways. But like I've said before, we do our best work when we work within the community. So right now, Brave, or with partners that are in the community. So right now, Brave operates in 11 states. We'll be in 20 by the end of the year. We'd love to find ways to bring solutions to Hawaii, but we would need to really think about the best ways to plug into the community. Of course, we would hire some people on the ground, but we'd also be bringing net new providers. And right now our providers speak 16 different languages, but I don't think we have any who speak Hawaiian. We would need to find ways to really think about how we partner with local organizations, which is why I love doing stuff like this, right? We get to be able to be exposed to organizations that are doing work looking at community health from a different lens than we are. We look at community health through the lens of the national virtual platform, right? And that brings something, but it doesn't bring everything. We can certainly augment the work that's happening on the ground. And when we're at our best, we're working with it.